Dear colleague, welcome to this presentation of Deep Brain Stimulation for Movement Disorders for Referring Physicians. Part 1. What is DBS and how is it done? My name is Patrick Blomstedt and I am Professor in Stereotactic and Functional Neurosurgery at the University Hospital of Northern Sweden at the Unit for Deep Brain Stimulation. I and my mentor, Professor Marwan Haris, have together experience from about 1500 DBS procedures and have written about 400 scientific papers on this topic. My intention with this lecture is to provide a brief overview of DBS for movement disorders, focusing on what is of importance for referring physicians. And this will, of course, to some extent be a reflection of our own experience. However, in order to provide you with a wider and deeper perspective, this lecture has been created in collaboration with some of the leading neurologists within the field of DBS. You can find this lecture and almost 200 others at the Stereotactic Academy at stereotactic.org, where we have gathered experts within the field of DBS from the whole world. This lecture is also the introductory lecture of a CME-accredited course for referring physicians, given in collaboration with a number of organizations. You will find this course at another website, stereotactic.se. To get access, you need to register, but all content is completely free for healthcare personnel. The course is intended for physicians meeting patients that might be eligible for DBS in their practice. I assume that most of you are neurologists, but there are variations around the world, and for that reason we will here provide also basic information. The course consists of 5 lectures. In the first part of the current lecture, we will look at what DBS is and how it is done. In the second part, we will continue with who to refer and what to expect. This will then be discussed in further detail in 3 lectures on DBS for the major indications, that is DBS for essential tremor, dystonia and Parkinson's disease. Those lectures might provide more information than you really need as a referring physician, but if you find this to be the case, just focus on what you deem to be of practical importance and listen to the other details in order to get a deeper understanding of the field. For those of you who on the contrary find the course content too meager, we are also suggesting other lectures and scientific papers for further reading. So, let's start by looking at how DBS is done and how it works. DBS is a stereotactic neurosurgical procedure, and stereotactic is basically space geometry. It is a method to identify any point in the brain with the mathematical coordinates of a 3-dimensional coordinate system. It is also the name of the technique which we are using in order to reach the deep structures of the brain based on these coordinates. Stereotactic neurosurgery is not new. It was introduced in 1947, but in that era lesions were made. Typically, a radiofrequency electrode was introduced into the structure of interest in the brain and heated until it coagulated the brain substance around it, thus producing a lesion. And this was the first effective treatment for Parkinson's disease. In the modern era, lesions have been mainly replaced with DBS. Electrodes, or so-called leads, are implanted into the deep structures of the brain and connected to a neuropacemaker to modulate pathological brain signals. The great advantage of DBS compared to lesions is that stimulation is reversible and that you can modify the stimulation after surgery with regards to effects and side effects. The introduction of DBS has been a success story, and we have seen a dramatic expansion of indications, targets and techniques, with more than 200,000 patients operated worldwide and with more than 15,000 scientific papers on PubMed. There are a number of different DBS systems on the market, but they all consist of the same basic components. We have an electrode, also known as a lead, of around 1.2 mm in diameter that is implanted into the brain. This is anchored to the skull using a small anchoring device and then attached with an extension cable to an implantable pulse generator, or IPG, popularly known as a neuropacemaker. We have also the external programming device and the patient's own control for communication with the IPG. When we want to insert an electrode into a certain point in the brain from outside the skull, we need to know where the target is in relation to a point of reference outside the skull. For this reason, we use a stereotactic frame or a frameless system. Thus, we attach a frame to the head to work as a reference point, and when we then perform an MRI, CT or X-ray to simultaneously visualize the frame and the intracranial structures. But in reality, we are not looking directly at the position of the frame. Instead, we attach an indicator box to the frame, from which we can calculate the location of the frame based on the markers in the indicator box, so-called fiducials. These fiducials are creating a three-dimensional Cartesian coordinate system encompassing the brain. We can then look at a map of the brain, also known as an atlas, and identify the structure of interest that is our target where we want to implant the electrode. Unfortunately, the map is not always in accordance with the individual patient's own anatomy. For that reason, most centers will today not trust the map, but will instead look directly at the patient's MRI in order to identify the structure of interest based on the patient's own anatomy. Of course, we do not always implant the electrodes in the same brain structures. We are targeting different structures, so-called targets, depending on the patient's symptoms. And here we see the most commonly used targets in DBS for movement disorders. The subthalamic nucleus or STN, the zona incerta with the above-lying VIM in the thalamus, and the pallidum or GPI. After having identified our target, the next step is to find a suitable entry point and a trajectory through the brain, avoiding blood vessels and sulci. When we have decided the target point and the entry point for the electrode, then we can calculate the coordinates for these points, and this is today done with the help of advanced navigation systems. In the OR, we will add the stereotactic arc to the frame. If we put this in its neutral position on the frame, then it would coincide with the origin, that is, with the center of the stereotactic system. However, we don't want to reach this, but our target structure for DBS, so we set the coordinates for this target so that the center of the arc becomes displaced and is now coinciding with our intended target. We see the same in this video, how the arc is recentered as to coincide with the target. The angles can then be set to the chosen point of entry, and an instrument such as a DBS electrode equal to the radius of the semicircular arc and inserted at the right angle to the arc will end up in the target point regardless of point of entry. The next step is the implantation of the electrodes. We can in this video of a man with hereditary tremor see how these procedures used to be performed at my department and how they are still done at most places around the world.
De spänner ju fast den, eller stabiliserar den i öronen, skruvar de in 2 skruvar. Och så börjar skruva åt kronan ordentligt och det var ju en spännande känsla om man säger så, i hela huvudet. Patrik, läkaren, kom in och då han började berätta just exakt i detalj vad som nu kommer hända och allting. Så jag lyssnade där och kände så ja, det här ska nog gå bra. En sköterska fick stå och hålla fast huvudet på mig. Och medan Patrik stod och borrade och tryckte ner den där borren. Så det var ju liksom Så man fick spjärna emot lite med nacken.
Och det är en lite ovanlig situation.
Ja, det är inte varje dag någon står och borrar hål i huvudet.
Nej.
Sen dricker jag jävligt mycket mjölk också.
Ja. Och håll handen rakt ut. Okej.
Jag håller.
Ja, och peka på näsan. Bra. Då är elektroden på plats. Inte så illa utan ström.
Allvarligt?
Ja.
So, let's look at this again. We can here see the introduction of the lead, and here we can follow the track through the brain on video. This is not part of the standard procedure, but only done for pedagogic reasons here. And we also see here how the electrode is introduced on an X-ray. If the patient is awake, then the effect can be tested directly during surgery. We see here that he's shaking in his hand and wrist. I increase the current a little bit, and you see he's still shaking in his hand and finger. I increase it a little bit more, and we see that now he's completely still. Another way of evaluating if the electrode is in a good place is by using microelectrode recording, or MER, where you look at the activity of the neurons in your target to see if this activity is in accordance with what you would expect. However, nowadays I perform all these operations with the patients asleep and rely instead on an intraoperative X-ray investigation for confirmation that the electrode has ended up where I intended, and this is becoming more and more common around the world. After the electrode has been implanted, it is connected to an extension cable, which is tunnelated under the skin down to the chest, where it is inserted into a neuropacemaker implanted in a pocket under the skin. Most patients will recover fast and feel well within hours and be mostly recovered from the procedure the day after. Normally, we will keep the patient for 3 days after surgery, and if anyone would like to see the whole procedure in detail, then you will find the lecture Implanting a DBS System at the Stereotactic Academy. There are many variations in how DBS is done around the world due to different traditions, the team's experience, reimbursement and other factors. Some of the most important being asleep or awake, as we have already discussed. The length of the procedure varies considerably, and in some places the tradition is to use extensive intraoperative testing, which might result in a very long procedure, which can be tiresome for the patient. In some countries, the procedure is divided into several operations performed at different days, stretching sometimes over several months. There are also variations in surgical details, such as if a stereotactic frame or another device is used, and where the neuropacemaker is placed. Instead of the chest, it is often placed at the belly, or sometimes in the armpit, or even in the buttocks. The imaging can be done in various ways, and not everyone will verify after surgery that the electrodes have ended up where intended. And the postoperative stay might vary, and some will discharge a patient to their home on the day after surgery. DBS is a technically advanced procedure, but it can be seen as a small procedure, albeit in a highly sensitive organ. And DBS is in experienced hands associated with few complications of a serious nature. But it is important to be aware of these risks, since DBS is not done in order to save lives, but in order to improve the quality of life in our patients. There are quite large variations in the reported rate of complications following DBS, and this is perhaps not surprising considering differences in experience and the many variations in how the procedure is done. I will here follow this detailed review of 2,200 patients and also mention my own experience. But to get a good appreciation of the risks, this should be discussed by the patient with the individual DBS center. Complications from the implants themselves, such as cable breakage, straining cables, and malfunctioning, occurs in about 2% according to the literature. Such side effects will not be life-threatening, but often minor surgery is required to correct them. I am personally more afraid of infections. These can occur within days after surgery, when you change the battery, or at any time due to unknown causes. They are seldom very dramatic. Most often, the patient will notice tenderness, redness, heat and swelling somewhere over the implant, and this might progress until the implant is exposed. In order to deal with this, it is most often necessary to remove some or all of the implants and to treat the patient with antibiotics for some time before the implants can be replaced. This is seldom a major threat to the life and health of the patient. In the literature, the reported number of infections and erosions is rather high, around 3% each. In our experience, less than 0.5% of our patients have suffered intracerebral hemorrhages, but these have all been small and with relatively modest and always transient symptoms, with full recovery within a short period of time. The frequency of hemorrhages varies considerably in different reports, probably due to differences in experience, patient selection and surgical techniques, but in the review reported here it was 4%. The number of large symptomatic hemorrhages is of course smaller, but they do occur and are in most cases the reason for the few deaths caused by DBS surgery. I should also mention edema. The mere introduction of an electrode into the brain will often create a small visible edema. This is sometimes noted as a so-called microlesional effect, and then most often as an improvement of the patient's symptoms, but in a few cases as a minor adverse effect, most often affecting the speech. Positive as well as negative effects will resolve with the edema within days or weeks. Large and symptomatic so-called idiopathic delayed onset edema are rare but have been described, appearing days to months after the operation, and spontaneous recovery is expected, but steroid treatment might be indicated. Sometimes a patient will contact the referring center to discuss suspected complications, and when dealing with suspected infections and erosions, then it is prudent to contact the DBS center immediately in order to save the DBS system if possible. This should also be done if the patient displays symptoms congruent with the development of a large delayed onset edema. Remember also that DBS malfunction due to battery depletion or other causes might be a medical emergency. Some patients with Parkinson's disease or dystonia might become severely affected if the stimulation is discontinued, and a few might even require intensive care. Other hardware-related problems such as straining cables, etc. are also best left to the DBS center. Suspected stimulation-induced side effects like problems with speech, balance, paresthesias, etc. are more problematic. Sometimes it is evident that this is a stimulation-induced side effect, like when a newly implanted patient develops a dysarthria that is immediately reversible upon turning the stimulation off, and then the stimulation parameters should be optimized by the DBS center. However, when a Parkinsonian patient, years after DBS, develop a problem with balance or speech, then it has most often nothing to do with DBS. But it will still most often be necessary for the DBS center to rule out this possibility. But it is important to use some common sense. We get many odd referrals, like a patient with full-blown pneumonia with high fever who was sent to us from another hospital in an ambulance because of what was called stimulation-induced breathing problems. Most medical problems in elderly patients are not DBS related, and it is best to treat these patients as all other patients, ruling out the most common explanations before considering if the DBS might be the problem. Suboptimally placed electrodes is a common problem with DBS. In this study of 28,000 patients in the USA, 15 to 34% of all DBS procedures were actually electrode revisions, most often due to misplaced electrodes and lack of effect. And the group of Auken reported that 36% of patients referred for suboptimal effect of DBS had misplaced electrodes, and these electrodes were often misplaced by 5 to 10 millimeters. This is in accordance with my own experience. I often get second referrals due to poor effect of DBS, and in most patients this is due to misplaced electrodes, often 5 to 10 millimeter away from the intended target, as seen in these examples of intended STN DBS. In my opinion, it is clearly the responsibility of the implanting DBS center to verify and document that the electrodes are well placed. But it is not uncommon that this is not done at all. Further, in some parts of the world, it is not unusual for a patient to be operated at one place before being programmed at a second place, and perhaps to move on to a third center over time. If you have such a patient and the effect of DBS in your eyes is poor, then it might be indicated to make sure that someone has performed a postoperative CT or MRI and confirmed that the electrodes are well placed, or if this has not been done, to send the patient for such an evaluation. Many hours might otherwise be spent on futile attempts at optimizing a patient not benefiting from the therapy. Further, albeit very rarely, it has happened that a lead has changed its position after surgery, after initially having been verified to be well placed, why one might want to confirm the location of the lead again in some cases. We will, after surgery and before the stimulation is started, identify the location of the electrode contacts. When the electrode is placed in the same manner in all patients, then we can estimate a similar response to stimulation. If the electrode is correctly placed, it is often possible to predict the most effective contacts reasonably well from its anatomical location. This information is further of value for understanding the encountered side effects. The stimulation can be started with an external programming device directly when the patient has recovered from surgery, but often the start is delayed, typically with about 4 weeks, to avoid influence from the microlesional effect, that is the edema surrounding the electrode immediately after surgery. The patient is further equipped with a remote control with which they can control the stimulation, check the battery level, and sometimes make minor adjustments of the stimulation parameters. The first thing we do is to perform a review to map the stimulation response from the different contacts. This can be done using low-tech solutions, but it is also possible to use visual models. Based on this, what is believed to be the optimal stimulation parameters will be chosen. We can shape the field of stimulation in various ways. The areas in the brain that we want to stimulate in order to reduce various pathological symptoms are not physically isolated entities. They are bordered and entangled in other structures where stimulation will cause unwanted side effects. We thus need to find stimulation settings with a stimulation field that will mainly encompass the intended target area while minimizing the spread outside of this. The most important aspect of stimulation is the location of the field of stimulation, and this is most strongly influenced by where we are letting the current exit the electrode and enter the brain, thus the contacts of the electrode. All electrodes have at least 4 contacts. These are 1.5 mm long and separated by a distance of 0.5 mm in the most frequently used models and by 1.5 mm in other models. Previously, all contacts have been ring-shaped and placed along the axis of the electrode, letting the current pass in all directions. But today, we have also directional leads, enabling us to move the field of stimulation away from the axis of the electrode. You can choose to activate one or any number of the available contacts. Adding more active contacts will spread the field of stimulation. And typically, stimulation is started with only one contact, and depending on various factors, sometimes we will add another contact as well. The amplitude is the strength of the electric charge delivered through the electrode. This is measured in volts or ampere. Current is a measure of the flow of electrical charge, that is the amount of electricity delivered to the tissue. In modern systems, the voltage will adapt to any change in the impedance, ensuring a constant current and a stable field of stimulation. The flow of electrical charge is not constant but delivered in short pulses, and frequency is the number of such pulses per second. And we will use high-frequency simulation in all common targets, typically with 130 Hz. The pulse width is the duration of each pulse, and this is measured in microseconds. The mode of action of DBS can be thought of as using electric current to replace the pathological signals in the neurons causing the various symptoms with nonsense signals. And the size of our field of stimulation varies with the stimulation parameters, but will often extend about 3 mm from the electrode contact. However, we need to remember that there are no specific centers in the brain for tremor or other such symptoms, but these symptoms are caused by pathological activity in various networks in the brain. The stimulation field itself from the DBS electrode will affect an area only a few millimeters away from the electrode, but since we are intervening in networks, this will have effects also far away from the electrode in other areas of the brain. In patients with unilateral DBS for tremor, the programming of the stimulation parameters is usually straightforward, and most patients will not need to come back for any adjustments during the first year. However, in patients with bilateral SDN DBS, the situation is more complex, and the patient will at our department return after 3, 6 and 12 months for adjustments. In these patients, it is necessary to gradually increase the stimulation strength while at the same time balancing the medication in order to get an optimal effect. Some patients will need additional visits, and there are large variations in how the postoperative programming is planned and done at different centers, with some neurologists preferring to see the patients every other week or so. In order for the patients not to become frustrated, it is important that they realize before surgery that the first 6 months can sometimes be an intensive period and that the improvement is gradual and can take time to realize. If the initial programming has been done meticulously, then no further adjustments are necessary over the coming years in most patients. But in some, a minor increase of the amplitude might be necessary due to increase of tremor. In another, a minor decrease might be necessary due to an increase in sensitivity to the stimulation. And there are, of course, more complicated patients as well. We can choose between rechargeable and non-rechargeable neuropacemakers, and these have different advantages and disadvantages, more or less suited for the individual patient. A rechargeable battery will last for 15 to 25 years depending on which brand is used, and a non-rechargeable for about 4 years. This is, however, very dependent on the energy consumption in the individual patient and varies in my own experience from 2 to 12 years. DBS is done in order to improve the quality of life of the patient, and after surgery the idea is that they should be able to forget that they have undergone this procedure. The implants will not break or change position if they fall or suffer minor trauma, and they can virtually do whatever they want without taking the DBS into consideration. However, the implants can be affected by external forces, which we need to take into account when performing cardioversion, diathermia, MRI and such. With modern implants, MRI can be done, but it is important to know which implants the patient has and to follow the specific protocols. When questions arises, it is best to contact the responsible DBS center. We are making our patients better with DBS, but to some extent this is a potential improvement that needs to be realized. Many patients with Parkinson's disease and dystonia need to learn again how to use their body in a more normal manner. Therefore, I believe it to be a good idea to send these patients for rehabilitation. I will send my own patients for 3 weeks of rehabilitation, 6 months after the procedure, when we expect to have a good effect from the DBS. But this is not a universal strategy, and other centers will have a different approach. And with that, I end the first part of this lecture, and I suggest that you now continue with the second part, where we will discuss who to refer and what to expect. Thank you for your attention.